Hello Medicos, good day to all of you. So this is Dr. BK for you, and today I am going to discuss about the lungs. So under the lungs I will be just giving a short introduction regarding the basic functions of the lungs and how do they appear, and then I will be discussing about the various parts of the lungs, then about its relations, borders and surfaces, then followed by the blood supply, the nerve supply, and finally I will be touching upon the bronchopulmonary segments, and then by usually as by any session I will actually wind it up with the applied aspects. Okay, so you all know right from your school days that pair of lungs are present in the thoracic cavity and they are the organs of respiration. So a lung is actually a soft, spongy, pliable structure. It is half cone shaped. Okay, it is actually half cone shaped because your able to see it is only convex on one side, then you have the apex, then you have the base of the cone, but the other side it is not convex, it is somewhat truncated. So it is only you have a half of the cone of this side and the other side, and both the lungs are actually separated by the structures in the mediastinum, especially the heart and the great vessels which actually emerge out of the heart or reach the heart. Okay, now we all know that the lung has a protective covering which is actually called as the pleura. So in the last session we have discussed in detail about this covering, that is the pleura, the two layers of the pleura, which is the pulmonary pleura which closely invests the lung, and then you have the parietal pleura. Okay, so between these two coverings you have the pleural fluid which is present, and that is the actual pleural cavity. So the lung is invested by the pleura. Okay, and then as I told you, it is porous and elastic. So if you put an adult lung in the water, it floats. You know why? Because it is spongy and porous because of the presence of the alveoli of the lungs. They are actually the air sacs which are present, mainly the functional unit of the lung where the gaseous exchange takes place. So because it is completely filled with air, so that is why it floats on water. Not only that, when you take a radiograph, X-ray of the chest, the lungs are actually black because the X-rays pass through it. It is radiolucent, it is transparent to the X-rays. So that is why it appears black. Now, fetal lung sinks in water. So fetal lung means the fetus, an unborn fetus which has not entered into this earth and it is not breathed this. It has not breathed this first, what you call breathe. So unborn fetus, even a full-term fetus, if you put the lungs on the water, it will sink. That is because still the respiration has not started, so it is not filled with air. Okay, so this, based on this, you can actually, what happens is you can actually decide certain medico-legal disputes, whether the fetus, if it is a feticide, whether it has been killed after it has given birth or in uterus itself and due to some demise, intrauterine demise has taken place. Okay, so this aspect of the lung floating in the water or sinking in the water has a medico-legal importance. Okay. Now the lung of adults, usually what happens is when we are born, the lung is actually pinkish in nature, but slowly what happens is it actually becomes grey or dark grey or black because of the deposition of the carbon particles. So much of air pollutants and the smoke from the vehicles we inhale, all these gets deposited on the lungs and thereby gives a black appearance. And this is more deposition is on the city dwellers because of the heavy congestion or the thick population of the automobiles or the vehicles. Okay. So with the short introduction, I will just directly move to the parts of the lung. So each lung, the upper end, it is actually not an end, the area of that lung which is somewhat pointed is actually called as the apex of the lung. Then the below, what you see here is the base of the lung. It has got an apex, it has got a base. Then this outer surface is actually called as the costal surface of the lung. The other surface which is facing the mediastinum is called as the medial surface or the mediastinal surface. Okay, so what is the medial or mediastinal surface? This is actually the costal surface or the lateral surface. Simply you can put it as lateral and the medial surface. Okay, and each lung has three borders: anterior border to the front, posterior border behind, and then a round border you see, which is actually called as the inferior border. Is actually called as the inferior border. Now, how do you decide the side of the lung, whether it is a right lung or left lung? Now, usually when you ask, people tell that okay, right lung has got 3 lobes, left lung has got only 2 lobes, right lung has got 2 fissures, left lung has got 1 fissure. Okay, now all this is correct, but sometimes what happens is you might be fooled by this because the fissures might get adhered to each other. There might be adhesions, and that might appears the right lung itself having only 2 lobes. Okay, so the best way is to decide or to find to which side the lung belongs is first place the lung in the upright position in such a way the pointed end apex is above and this broad base is below. Okay, first thing you should do that. Then second thing, very important, you should see that this thin border is or the sharp border, anterior border facing to the front, and this round border facing behind. So this itself will solve 90% of your problem. So facing the lung upright with apex downwards and the base below pointing downwards, and then anterior border facing towards the front and posterior border facing towards the facing behind. So when you do that, then naturally what happens is this convex surface, the costal or the lateral surface, this convex surface should face laterally. So to which side the convex surface faces? Naturally it belongs to that side of the lung. If the convex surface for the right side, it will face to the right hand side of the right lung. Okay, if the other two factors which I told you, if you would have followed correctly, that apex pointing upwards, base downwards, and the sharp anterior border facing towards the front. Now we will see the presenting parts, its features and its relations one by one. First, we are going to deal with apex. So apex is actually not a point. Okay, it is actually that part of the lung which is above the first rib. Okay, so this whole part of the lung which is above the first rib is actually the apex of the lung. It is 2.5 centimeters above the medial end of the clavicle and 3 to 4 centimeters above the first rib. So even this aspect I have discussed in detail in my previous class while I was dealing with the pleura in the cervical pleura. I again told you. Okay, I have already mentioned to it. So 3 to 4 centimeters above the first rib, but the uppermost end, the highest point of the apex, does not extend beyond the neck of the first rib. Okay, does not extend beyond the neck of the first rib, and this apical part of the lung is actually covered by the cervical pleura. And not only that, apart from that, in addition, the cervical pleura is again covered by the suprapleural membrane. So it gives an extra protection for the lung, because the lung, this part of the lung is not within the rib cage, it is in the root of the neck. So naturally, any stab wounds by any pointed object, if you stab that area, it will puncture your lungs. So that is why to some extent the suprapleural membrane is present. Okay. Now, if you look at both the lungs, the anterior, lateral and the posterior relation of the apex of the lung is the same for the both sides, but only the medial relations of the right lung and the left lung, the apex of right lung and the left lung, the medial relations are going to differ. Okay, so what is actually thoracic inlet syndrome? So I have just come to you after explaining the other mainly the relations of the apex of the lung. So after dealing all the relations of the apex of the lung, then I will tell you what is thoracic inlet syndrome, so you will better understand. So now you are able to see the apex. Now anteriorly, the apex of the lung anteriorly will be related to the subclavian vessels. Okay, so mainly the subclavian vessels, subclavian artery behind, and then the subclavian vein in the front. Both sides it is the same, and also the insertion of scalenus anterior muscle. Okay, you have three muscles: scalenus anterior, scalenus medius, and scalenus posterior. So anteriorly it will be related to the insertion of the scalenus anterior muscle. So laterally it will be related to the scalenus medius muscle. Laterally, the apex of the lung will be related to the scalenus medius muscle, and posteriorly, behind the lung, posterior part of the intercostal space. So first intercostal space, thereby the first intercostal nerve will be related. Then first thoracic ganglia, sympathetic trunk, superior intercostal artery, which is from the costocervical trunk of the subclavian artery, first posterior intercostal vein. So these are the relations posteriorly, which is again same for the right side and the left side. So mainly it is related to the sympathetic trunk, superior intercostal vein, posterior superior intercostal artery, first posterior intercostal vein, and then your thoracic sympathetic chain. So laterally, as I told you, it is the scalenus medius muscle. Now coming to the anterior relations. Okay, so the right lung, it is related to the, so this is your right brachiocephalic vein. So it will be related to the right brachiocephalic vein, and then the brachiocephalic trunk. Then you have the right edge of trachea. You also have phrenic nerve, which is descending medial to the pleura. Phrenic nerve, of course, it is not shown here, with the pericardiophrenec vessels. Phrenic nerve, which is going to supply the diaphragm, and the pericardiophrenec vessels will be related, right side. Okay, so mainly the right brachiocephalic vein, artery is the brachiocephalic trunk, then the right edge of trachea. Left side, you see, it will be related to the subclavian artery, left subclavian artery, left brachiocephalic vein, then esophagus, it will be related to the esophagus. So subclavian artery, left brachiocephalic vein, esophagus, and of course thoracic duct, the largest lymphatic trunk or a lymphatic duct, which is again not shown in this view. Just understand, right side it is the right, left side it is the left brachiocephalic vein, subclavian artery, esophagus. Left, right side trachea, right brachiocephalic vein, brachiocephalic trunk. Okay, and here in between these vessels and the pleura you have the phrenic nerve and the pericardiophrenix vessels actually descending. Okay, now what is thoracic inlet syndrome? So this, you know what is inlet of thorax. Anatomists call it as inlet of thorax, but clinicians, they consider this as the outlet. Now, any tumor affecting the apex of the lung, any mass or neoplasm or tumor affecting the apex of the lung, which will compress these structures, either right side or left side. So based on that you will have symptoms. One is, if the brachiocephalic vein is compressed, then venous drainage of your upper limb, head and neck will be affected. So engorgement, edema of the face and limbs. If the vessels, subclavian artery on the left side is blocked, then naturally decreased pulsations, wrist. What happens is, pulsations you won't be able to feel in the radial artery because the main artery, the subclavian artery itself is blocked. So these are all vascular symptoms. Okay, these are all vascular symptoms. Then if the phrenic nerve is blocked, then hemidiaphragm, that half of the diaphragm will be actually, what happens is that half of the diaphragm will be paralyzed. Hemidiaphragm. Then in the tracheoesophageal groove, what happens, especially the left side, one nerve will wind around and go above, which is called as the recurrent laryngeal nerve. So if that nerve is compressed, then you get hoarseness of voice. Okay, because it supplies the muscles of the larynx, what you get is the hoarseness of voice. So this is actually called as the thoracic inlet syndrome. Okay, so edema of the face and the upper limb, decreased pulsations of the wrist, arterial pulsations, hemisection of the diaphragm and hoarseness of voice, or might be due to the neoplasm or any tumor affecting the apex of the lung. Now coming to the base. So the base of the lung is also called as the diaphragmatic surface. It is concave. The base is actually concave, and the concave or the depthness of the concavity, it is more concave on the right side to accommodate the liver. Okay, so immediately the inferior surface of the base is related to the diaphragm. Below the diaphragm, the right lung is related to the liver, left lung is related to left lobe of liver, fundus of stomach, and then the spleen. Okay, left lobe of liver, fundus of stomach and spleen, the diaphragmatic surface or the base of the lung, left lung relations. Right lung, it is only the liver. Okay, so we have seen about the apex of the lung, we have seen about the base of the lung. So now we will see across the various surfaces of the lung. The lateral surface are also called as the costal surface. So it is actually convex and it is related to the intercostal muscles or intercostal space, ribs, costal cartilage, and then intercostal muscles in between them. Naturally, there are corresponding nerves and vessels which are present in each space. So it is related mainly to the thoracic wall, internal surface of the thoracic wall. Okay, ribs, intercostal muscles with its vessels and the nerves. You are able to understand. And all this, deep to all this, you have the endothoracic fascia, which is actually present between the intercostal space and your parietal pleura. Then of course you have the pulmonary or the visceral pleura. So these are the coverings from or the layers from superficial to the deep. Okay. Medial surface can be divided into two parts, a posterior vertebral part which you are able to see here, and then the anterior mediastinal part. Posterior vertebral part, you are able to see it is related to the first 10 bodies of thoracic vertebra. Bodies of thoracic vertebra, intervertebral discs, it is related to the body of thoracic vertebra, intervertebral discs, posterior intercostal vessels, and then splanchnic nerves, greater, lesser and least splanchnic nerves. So they are actually branches from your sympathetic trunk. They are mainly responsible for the what you call the sympathetic outflow, thoracolumbar outflow. Okay, so greater, lesser and least splanchnic nerve. So don't worry about what is this, we will discuss that in the autonomic nervous system of the thorax. Okay, so it will be related now. For the time being, you remember that it is related to the first 10 bodies of the thoracic vertebra, intervertebral discs, then intercostal posterior part where the posterior intercostal vessels will be actually emerging. Next, anterior mediastinal surface. We are going to see about the mediastinal surface. This is actually the anterior mediastinal surface. So far we have seen the posterior medial surface due to posterior vertebral part and anterior mediastinal part. Vertebral part only I told you it is related to the upper 10 thoracic vertebra. Now we will come to the mediastinal surface. So again the relations and the structures which are present here is different for both the lungs. That is for the right lung and the left lung it is different. Now first let us understand the structures which are present in the hilum. Okay. So mainly on the mediastinal surface you see the hilum and then you see the pulmonary ligament. Okay. Now hilum is that part of the lung where the root of the lung, the root structures of the lung enter. So hilum means entry point or gateway. So gateway, it is not necessarily entry point because some structures leave through a viscera, so it can also simply called as an gateway instead of precisely telling it as entry point. Okay. Now the place where the root of the lung, root structures enter the lung is actually called as the hilum. So the structures in the hilum are actually different again for the both lungs, that is the right lung and the left lung. Now here you are able to see the right lung hilum structures. You should know this by heart in order from above downwards, from before backwards. So above downwards means from superior to inferior, before backwards means from anterior to posterior. So above downwards right lung, arterial bronchus, pulmonary artery, principal or hypoarterial bronchus, inferior pulmonary vein. Okay, pulmonary artery remember will be in blue color because this takes the deoxygenated blood. Pulmonary vein is red in color because it carries oxygenated blood. One pulmonary artery, two pulmonary veins. Okay, so don't get confused, sir. Two structures are here. That is because when you go a little bit deeper, what happens? It gets branched. So that is why it is shown here. Okay. So from above downwards, eparterial means above the artery, eparterial bronchus, pulmonary artery, hypoarterial or principal bronchus, lower pulmonary vein. This is the order from above downwards. From before backwards, superior or anterior pulmonary vein, pulmonary artery, principal bronchus. Okay. This is actually from before backwards, superior or upper pulmonary vein, pulmonary artery and principal bronchus. Okay. So it's very simple. Now going to the left lung. In left lung, what happens is the hyparterial bronchus is missing because the left lung has got only two lobes it has. So the hyparterial bronchus is missing. So from above downwards, it is artery, pulmonary artery, principal bronchus, inferior pulmonary vein. Okay, you just remove the hyparterial part. Then it becomes the hilum of the left lung. Same way from anterior to posterior, it is the upper pulmonary vein followed by pulmonary artery, and then it is the principal bronchus. Upper pulmonary vein, pulmonary artery and principal bronchus. See, anterior to posterior, remember the vein should come first because vein only will be present anterior. If it is present in between or if it is present posterior, naturally it won't be able to dilate and it might get compressed. There will not be any effective venous return. So always remember, when actually vein means if there are other structures, it will be present anterior to it or superior to it. Okay. Now you might ask, sir, this is actually present below, but for that only again, for the inferior pulmonary vein, we have the pulmonary ligament which acts as a reserve space, and these two definitely are not going to compress this one. Okay. So apart from this, there are other structures like bronchial vessels, lymphatics and nerves which are actually passing through the hilum. Bronchial vessels means bronchial arteries and veins. Then you have nerves, sympathetic and parasympathetic nerves, and then the lymphatics which leave the lung. So now we have seen about the hilum of the right lung and the left lung. Now we will see the other relations of the mediastinal surface. So this is the mediastinal surface of the right lung. This area in front of the hilum and somewhat slightly in front and below the hilum is the cardiac impression. Okay, this is actually called as the cardiac impression. This is for the following chambers of the heart. Okay, so mainly the right ventricle and the right auricle or atrium. This forms an impression on the cardiac impression. Below the hilum and behind the cardiac impression, this small area is for the inferior vena cava. So inferior vena cava has got only very small impression because immediately after piercing the diaphragm, the inferior vena cava will open into the right atrium. Okay, so a very small impression only you will be able to see for the IVs, groove for the inferior vena cava. Okay. Now above the cardiac impression in front of the hilum, you see this is the groove for superior vena cava, and this groove continuing for the right brachiocephalic vein. Okay, superior vena cava and right brachiocephalic vein. You are able to understand the right brachiocephalic vein. Now, arching above the lung, arching above the right lung is the arch of Azaegos vein. Okay, so as the arch of Azaegos vein, actually the Azaegos vein is coming and opening into the superior vena cava. You are able to understand that? Then behind the groove for the brachiocephalic vein, you have an area for the brachiocephalic trunk artery. Right sided first branch from the aorta, brachiocephalic trunk, and then behind that you have the tracheal area for the right edge of the trachea, and then the vagus nerve. Then behind, exactly behind the hilum, you have an area for the esophagus, right edge of the esophagus. Only one side you are able to see because esophagus deviates to the left side twice. So the main impressions is cardiac impression for the right ventricle and the right atrium, superior vena cava, brachiocephalic vein, right brachiocephalic vein, arch of Azaegos, tracheal impression. Remember, this is arch of Azaegos. It is very small but arched, because like the same arch you will see in the left lung. So don't get confused, and you should not tell this is left lung. Now before that, you actually compare how actually these structures make an impression. So we have seen that the right atrium, this right ventricle and part of right atrium for the cardiac impression. This is the superior vena cava. This is the brachiocephalic vein, and just behind it, brachiocephalic trunk, arch of Azaegos vein you are able to see here, and then the tracheal impression. Next, coming to the mediastinal surface of the left lung. So again, left lung mediastinal surface, in front and below the hilum is the cardiac impression, and see the area for cardiac impression. It is large and extensive, much larger and extensive as compared to the cardiac impression of the right lung. So this impression is mainly for the left ventricle, part of right ventricle also, and then left auricle, left ventricle, and also part of the right ventricle. Okay, this is the hilum. Then above the hilum, you see this arch. See actually the breadth or wideness, width of this arch. This is arch of aorta. Okay, whereas there you have seen a small arch which is somewhat narrower, not as thick as this. That is the arch of Azaegos vein in the right lung. In the left lung, what you are able to see is the arch of aorta continuing downwards as the descending thoracic aorta. This arch you are able to see, it is again continuing as the descending thoracic aorta. Okay, then from the arch of aorta above, you will see the groove for the subclavian artery. This is a branch from the arch of aorta. Then what happens is, you will also see for the common carotid. Then arch of aorta, descending thoracic aorta. This is groove for the subclavian artery. And here posteriorly, you will see the esophageal impression at one place. Then below, in front of the descending thoracic aorta and behind the pulmonary ligament. So in between the pulmonary ligament and descending thoracic aorta, again you have an area for the esophageal impression. So twice above and below. It deviates to the left lung twice. The esophagus makes impression at two places. Cardiac impression, arch of aorta, descending thoracic aorta, subclavian artery, then esophageal impression twice on the left lung. Okay. So mainly what happens is, these are the major impressions on the mediastinal surface. So before identifying or discussing about the mediastinal surface, so that's why if you want to be sure, first identify the side of the lung. I told you in the beginning sessions, that is in the beginning slides, I told you how to identify the lung. So first make sure whether it is right lung or left lung, and then naturally you will be able to identify these impressions, because it is not going to be as exactly how we have seen in the pictures, whether in the atlas or books or slides, wherever diagrams you see. For us to understand what happens, these diagrams are present very neatly, but in the exact specimen, when you see, naturally it is not going to be. Sometimes the arch of aorta might be very thin. Okay, in that case you might have a doubt whether it is right lung or left lung. It might be like arch of Azaegos. In that case, you first confirm or identify the side of the lung, then don't worry about the size of the impressions. You can confidently discuss about these mediastinal relations. Okay, then anteriorly, one more impression for the left brachiocephalic vein in the front. So that is the arch of aorta you are able to see here, descending thoracic aorta. This is for the left ventricle, left auricle, and also the right ventricle cardiac impression. Esophageal impression here above, behind the common carotid impression, and here also it will be present, which is actually hidden from your view. Now coming to the borders of the lung. So first is the anterior border, which is sharp, and this anterior border follows the costo-mediastinal line of reflection. So from the medial end of the clavicle, from the apex you can draw to the medial end of the clavicle. Then from there what happens up to the fourth rib, second to fourth rib, the anterior border actually are very close to each other. After that, from the fourth to sixth rib, the anterior border of left lung makes a deviation 3.5 centimeters from the lateral border of sternum. Fourth to sixth rib, it makes a deviation 3.5 centimeters from the lateral border of sternum, and that deviation is actually called as the cardiac notch. Okay, and that is actually called as the cardiac notch from the fourth to sixth costal cartilage. Okay, then if you look at the posterior border, anterior border is thin and sharp, and you also see the cardiac notch only for the left lung. Okay, posterior border is actually thick and rounded, and it is present or occupies the paravertebral gutter. So that is, paravertebral gutter is nothing but which is present on either side of the vertebral column, because the vertebrae are somewhat projecting anteriorly. On either sides you see somewhat hollowed out longitudinally, and that is actually called as the paravertebral gutter. Inferior border, as I told you, it is round and separates the base from the mediastinal surface, and also separates the base from the costal surface. The inferior border of the lung is present at the sixth rib mid clavicular line, eighth rib at the mid axillary line, and 10th rib at the scapular line. Okay, this is the lower border of the lung. Okay, 6th, 8th and 10th, whereas you add the number 2 to all these in case of the lower border of the pleura, 8th rib, 10th rib and 12th rib respectively for the mid clavicular, mid axillary and the scapular line. Okay, so that is about the inferior border. You are able to see the posterior border of the lung. So up till the 10th rib in the scapular line, it is rounded, thick and rounded, the posterior border, whereas the anterior border is thin and sharp. Okay. So we have seen about three borders: the anterior border, the posterior border, and then we have seen about the inferior border of the lung. We have also discussed about the surfaces. Now we will come to the lobes and fissures of the lung. As you all know, right lung has got two fissures. One is actually called as the oblique fissure, another one is the horizontal fissure. Whereas the left lung has only one fissure, the oblique fissure, and two lobes. Now the oblique fissure is very, very important. It actually starts behind the hilum. Okay, above and behind the hilum it starts, then cuts the posterior border at the level of T3, T4 spine, then comes forwards and laterally, comes forwards and downwards. Okay, then it passes through the fifth intercostal space at the mid-axillary line, fifth, and then finally to the sixth costochondral junction it comes and finishes. Thereby it ends. Okay, so here you are able to see this is the oblique fissure. Now for the right lung, from the oblique fissure at the level of the fourth intercostal space, you see another line which is running transversely, which is called as the horizontal fissure, which is actually called as the horizontal fissure. Whereas the left lung has only oblique fissure, there is no horizontal fissure. Now the oblique fissure is very important because it is the line of cleavage or the plane of cleavage, because during inspiration your upper part of the lung moves forwards and laterally, lower part moves downwards and backwards. Okay, so that is the importance of the oblique fissure. Forwards and laterally, the upper part of the lung above the oblique fissure. The lower part of the lung moves downwards and backwards, that is that part of the lung which is below the oblique fissure. And the oblique fissure of the left lung is more vertical. Okay. Okay. So we have seen about the two lobes, the upper lobe and the lower lobe in case of the left lung, upper lobe, middle lobe and lower lobe in case of the right lung, three lobes. Now we also something called as Azaegos lobe. Okay, so there are three types of Azaegos lobe. One is upper and lower Azaegos lobe, and other one is the lobe of Azaegos vein. Okay. So accessory lobes, apart from these three lobes, are mainly you have accessory or supernumerary lobes are actually called as the Azaegos lobes. As I told you, two types. One is called as the upper Azaegos lobe, another one is actually called as the lower Azaegos lobe. Now this does not bear any importance, but whereas there is one more type which is called as the lobe of Azaegos vein. What happens is you see a deep fissure which is dividing the apex of lung into medial and lateral parts. Okay, dividing the apex of the lung into medial and lateral parts. You are able to see that on the depth of this fissure, you see the Azaegos vein is lodged, and you have a fold which is running called as the mesoazaegos. Okay, it is suspended in a fold which is actually called as the mesoazaegos. So instead of the Azaegos vein making an impression, it is getting deeply buried. It is actually getting within the substance. It is getting deeply buried with the substance. That is because the bronchus grows more medially. Okay, and because of that the lobe of Azaegos vein is formed. Now why actually this lobe of Azaegos vein gains importance is because in your radiographs, if this lobe of Azaegos vein is present, it will show a dense pea-sized shadow on the apex of the lung. Okay, because the remaining part will be black, whereas this will show a dense pea-sized shadow on the apex of the lung, which you should not mistake for any carcinoma of the lung or any pathology of the lung. You should rule out first whether it is the lobe of Azaegos vein. So that is why you should know or have knowledge about the lobe of Azaegos vein, which is different from the Azaegos lobe. Okay, so mistaken for enlarged lymph nodes in radiographs, it will produce a shadow in the radiographs. Okay. Bronchus, so each lung has got right principal bronchus and the left principal bronchus. If you look at the right principal bronchus, it is wider, shorter and then steeper. Okay, it is wide, short and runs more steep, almost vertical, whereas the left lung, it is longer, narrower and more horizontal, somewhat transversely oriented, the left lung. Okay, the place where the trachea divides into the two principal bronchus is actually called as the carina. C-A-R-I-N-A, it is actually called as the carina. Okay, because of this shorter, steeper, any inhaled foreign body tends to pass through this right principal bronchus and get lodged in the right lung. So any foreign body, what happens is more commonly, more chances of it getting lodged in the right lung because of this nature of the principal bronchus of the right lung. So a brief comparison of the difference between right and left lung is the whole lung is slightly larger, short and wide, where this is long and narrow. No cardiac notch. Anterior border shows cardiac notch and a tongue shaped process which is called as the lingula. Okay, below the cardiac notch it projects as the lingula. Two fissures, three lobes, one fissure, two lobes. Hilar structures, you have eparterial, hyparterial bronchus, here only one bronchus, one bronchial artery, two bronchial arteries. Okay, then this is bronchopulmonary segments, 10 bronchopulmonary segments for the right lung, whereas here 8 to 10, it might be 8 or sometimes 9, okay, in the left lung. These are some of the differences. Now we will pass on to the bronchopulmonary segments. So what is actually bronchopulmonary segments? You all see, this is actually the trachea. Okay, so the trachea divides into the principal bronchus or the primary bronchus, which is again dividing into secondary bronchus. The secondary bronchus gives rise to the tertiary bronchus. Okay, so the secondary bronchus gives rise to the tertiary bronchus. Secondary bronchus, lobar bronchus, then this is actually the segmental bronchus. Tertiary bronchus is actually called as the segmental bronchus. Now, the area of lung or portion of a lung which is aerated by a single tertiary bronchus is actually called as the bronchopulmonary segment. So, area of that lung, that area of the lung which is aerated by a single branch of the segment of the tertiary bronchus. Okay, this is one, this one, this one. So, like that, aerated by the one segment of tertiary bronchus is called as the bronchopulmonary segment. Okay. So, on the right side there are 10 segments and left side usually it is 9 segments. Now, if you look at each segment, it is somewhat wedge shaped. Okay, it is somewhat wedge shaped. The base of the wedge is nearer to the surface of the lung, whereas the apex is pointing inwards. Okay, wedges. You know what is a wedge? Okay, so like segment of your what you call orange fruit, it is somewhat wedge shaped, or potato wedges. You would have had potato wedges when you go to any of these what do you call famous outlets. Okay, so adjacent segments, one bronchopulmonary segment and other bronchopulmonary segment are separated by intersegmental septum. Intersegmental septum is present. What runs in the septum is the tributaries of the pulmonary vein. So each segment is wedge shaped, base nearer to the surface, and the apex is pointing deeply. Each segment or the adjacent segments are separated by the septa, intersegmental septa, and in the septa you see the pulmonary vein, they are intersegmental. But whereas the tertiary bronchus and the pulmonary artery are segmental in nature, they are not intersegmental, they don't run in between the segments but they run within the segments. Your pulmonary artery, pulmonary vein is intersegmental. Okay, so I told you bronchus is accompanied by pulmonary artery, whereas the pulmonary vein is intersegmental. Now because it is intersegmental, okay, so a tributary of pulmonary vein can drain more than one bronchopulmonary segment. So for example, this can drain this and this more than one. So the area of the lung which is drained by this single tributary of pulmonary vein is actually called as the bronchovascular unit. Area of lung drained by intersegmental tributary of the pulmonary vein is actually called as the bronchovascular unit. Okay, so now you know what is the difference between the bronchopulmonary segment and bronchovascular unit or segment. So now we will come to the subdivisions. Now why you should know these segments? That is because mainly because of this, any infections of the lung can be drained naturally without any surgical procedure or any other what you call invasive procedures. You can assume the patient to take different positions, turn the patient into various positions, and naturally what happens, the infected material can be drained. Okay, the septa, as I told you, in between the segments, intersegmental septa is there where the pulmonary vein runs, tributary of the pulmonary vein runs. This septa prevents the spread of infections only to some extent and some minor infections, but this septa does not prevent the spread of carcinoma or tuberculosis. Okay, carcinoma or tuberculosis. And again, apical segment of lower lobe and posterior segment of upper lobe are common sites of lung abscess, because in the supine position they are more prone for the infections. Any infection can immediately go and settle into the apical segment of the lower lobe and posterior segment of the upper lobe. Posterior segment of upper lobe and apical segment of the lower lobe. Okay, so because they are more dependent in the supine position. Just now I told you that. Okay. Now here you are able to see the bronchopulmonary segments. So to label the bronchopulmonary segments, right side you have the apical, anterior and posterior. You have the apical, anterior and then posterior. Okay, you have the apical, anterior and posterior. For the middle lobe you have medial and lateral. 3 plus 2, 5, and lower lobe again you have 5 bronchopulmonary segments: medial basal, posterior basal, anterior basal, lateral basal and again apical. So upper lobe it is apical, anterior, posterior, right lung. Middle lobe medial and lateral. Lower lobe 5 apical, anterior basal, posterior basal, medial basal, lateral basal. Okay. Now coming to the bronchopulmonary segments of the left lung. Again it is apical, anterior, posterior, superior lingular, inferior lingular. Okay, superior lingular and inferior lingular, apical, anterior, posterior. Again 5 segments for the upper lobe, even though there is no middle lobe. 5 segments for the upper lobe. Lower lobe, what happens? Again it is apical, lateral basal, anterior basal, posterior basal. The medial basal which you see on the right side is usually suppressed on the left side. So that is why you have 9 bronchopulmonary segments for the left lung. 9 bronchopulmonary segments for the left lung. Okay. The medial basal usually is suppressed for the left lung. So coming to the blood supply of the lungs, respiratory part, that is your terminal bronchiole, are all supplied by the pulmonary arteries. Conducting part, okay, so your lobar bronchus are all by the bronchial arteries. One right bronchial artery and 2 left bronchial arteries. They are branches from the thoracic aorta. They are actually branches from the thoracic aorta. Okay, what is hemoptysis? So hemoptysis is actually coughing of blood. Okay, so when there is any rupture, naturally what happens is these blood along with the sputum, what happens is coughing of blood takes place, which is actually called as the hemoptysis. Veins, you have superficial and the deep veins. They terminate into pulmonary veins or left atrium directly to the pulmonary veins or the left atrium. Superficial and deep set. Superficial set, they might actually drain your pulmonary pleura and then the adjoining part into the Azaegos vein. Okay, the deep set might actually drain into the left atrium. Lymphatics, again you have superficial and deep sets. They drain into bronchopulmonary nodes, hilar lymph nodes. Then from there they go to the tracheobronchial nodes. which form broncho-mediastinal lymph trunk, and they will drain directly into the thoracic duct on the right side and to the right jugular lymph, thoracic duct on the left side and right jugular lymph trunk on the right side. Mainly hilar lymph nodes. From there they go to the tracheobronchial nodes, and from there they may drain to the main lymphatic trunks. Nerve supply is by sympathetic and parasympathetic, okay, which is in the form of pulmonary plexus around the lung root. They have both sympathetic and parasympathetic. Sympathetic is actually by the vagus nerve, which is responsible for bronchoconstriction and secretomotor to the bronchial glands. Always parasympathetic is secretomotor. Sympathetic from T4 to T5 thoracic ganglia. T4 to T5 thoracic ganglia. So fibers arise from postganglionic fibers and takes part in the pulmonary plexus. They are mainly bronchodilator and vasomotor. Okay, they are mainly bronchodilator and they are actually vasomotor. They are motor to the blood vessels. Okay, sensory is again from the parasympathetic part. So hemothorax. So hemothorax is mainly what happens is collection of blood, which again we have seen in the pleura itself. Then pulmonary collapse, bronchiectasis, emphysema. The alveolar sacs, they are like elastic recoil. Sometimes what happens is in bronchiectasis they might get damaged, okay, and they might bulged out. So that effective respiration or exchange of gases will not take place. Okay, tuberculosis. So here you are able to see a tuberculosis lung. Okay, so near to the hilum, if you see some white shadow, it is due to the bronchial vessels. But apart from that, when you see some white patches, that is because of the tuberculosis infection. Then carcinoma of the lung. You are able to see a white round mass. So this is actually called as the carcinoma of the lung or lung cancer. So both are mostly common in smokers, cigarette smoking. Okay, causes carcinoma of the lung and also tuberculosis. Okay, so tuberculosis is mainly an infection. Then ILD or interstitial lung disease. So this mainly comes in rheumatoid arthritis. You call them as rheumatoid lung autoimmune disorder. What happens is the lung parenchyma is actually normal, it is not affected, but the connective tissue disease, interstitial lung disease is a connective tissue disease. So the interstitial areas of the lung, they might actually get inflamed and fibrosed. So naturally that might also interfere with the normal respiration. So emphysema, as I told you, what happens is the alveolar walls are actually damaged. Then you have COPD or chronic obstructive pulmonary disorders. Then lobectomy. I will come to the COPD in the next slide. Lobectomy is actually removal of the lobe of the lung. Okay, might be in carcinoma of the lung. Naturally, if lobectomy is removed, and in certain cases it has been proved that even if the one of the lobe of the lung is removed, especially the middle lobe of the right lung and the lower lobe of the left lung is removed, the patient can actually lead a normal life. Yeah. So chronic obstructive pulmonary disease is actually a combination of symptoms where you get chronic bronchitis, emphysema, wheezing with weight loss. You have dyspnea, difficulty in breathing, cough with sputum and chest tightness. Here you see what happens, this is the normal bronchiole. Here bronchoconstriction takes place because of the inflammation. Okay, chronic bronchitis, sometimes acute bronchitis also takes place. So suddenly you get wheezing due to any allergic reactions. So it depends from person to person, due to dust, pollen, due to some even some what you call food items if you are not allergic to certain food items. It depends from person to person. For even peanuts or milk, or in some cases of seafood, all those things can bring about bronchoconstrictions. Extreme weather conditions, in cold climate, it might bring bronchoconstriction. This is acute. But if you have a chronic bronchitis with inflammation, excessive mucus, weight loss, and dyspnea and emphysema, especially degraded alveolar membrane, they all represent to the COPD or chronic obstructive pulmonary disease. Okay, so that is about the lung for you. Thank you very much for your patient listening. We will meet again in one more lecture.